Hello, everyone, and welcome to Mindshare Partners Expert Interview Series, where we highlight thought leaders in the workforce mental health movement. Today, I'm excited to speak with Patricia Pittman, also going by Polly. She is a professor of health policy and management and director at the Fitzhugh Mullan Institute for Health Workforce Equity at George Washington University. The Institute has an impressive body of work focused on moral injury, an increasingly common, albeit less known workplace experience. So today we'll dive in to understand what moral injury is and ways to combat it. With that, Polly, it's great to have you with us.
Thanks, Bernie. Thanks for having me on.
So for those less familiar, can you define for us what moral injury is?
We at the Workplace Change Collaborative, which is a technical assistance center that was funded by HRSA to support 44 grantees working in the area of health and public safety on this issue of burnout and moral injury. We've defined it as the following, a very technical definition. It's the impact of perpetrating, failing to prevent, or bearing witness. So it's not actually something someone has to do. You could just witness it to acts that transgress deeply held moral beliefs or expectations. So it's a situation of powerlessness in the face of something that you perceive to be unethical. In the case of nurses, which is the occupation that I've studied the most, there is a clear sense of sort of what their duty is within the healthcare system, in particular with regard to the idea of advocating for patients and families. And often the moral injury occurs around the inability to do that, or the sense that the system doesn't recognize that that's the role that they've been trained to play. And so when they're unable to do that, when they're silenced, when their viewpoints aren't acknowledged over and over again, that produces the sense of moral injury. And it's very related to this idea that they can't do the work that they trained to do.
Yeah, absolutely. And I feel like this touches on my next question of increasingly outside of healthcare and within healthcare, we're called to do a lot of things that do and don't align with our core values, and increasingly the role of an organization's values as what brings us to work. So my next question is just, in what ways does moral injury show up in other industries or roles? Especially nowadays, we hear a lot of about layoffs and HR folks kind of tasked with rolling out these kind of
Mm.
downsizing of teams. So what kind of other roles or industries does moral injury show up in?
Yeah, I mean, one can only imagine what some of the supervisors in the federal government are experiencing as they lay off folks and claim that there was an issue of performance when it was just a layoff. I mean, that's a classic kind of a
Mm,
situation. But, over and beyond the current situation, I think education, for sure, teachers are experiencing things that are very similar where they feel it may be because the leadership is not particularly enlightened. It may be because of just the massive bureaucracy in the institution of education, but often teachers feel that they can't do right by their students, whether it's because, they're teaching to the test, or they're, you know, um, frustrated because they don't have enough time for children, young children in particular, to play, or, whatever the issue is. I think day in, day out, feeling like they trained to do something wonderful for children, and then they're unable to do it day in and day out, can create, for sure, moral injury. I would think that certainly the police, the DC police that were present on January 6th, felt that the authorities were not protecting them, was a source of betrayal. I think, we see this in all kinds of public safety workers if they feel like they don't have the resources, legal aid, lawyers who are working for very low salaries and are not given the resources they need to be able to defend their clients. I think it's not exclusive to healthcare. The thing about healthcare that is new, well, first of all, we had a pandemic. In the early stages of the pandemic, healthcare organizations stepped up and they were very generous and they were very committed. And
hmm
then as the financial constraints became clearer, they became less so. And I think the disenchantment became more exacerbated towards the end of the pandemic. But, pandemic aside and the scars aside, the trauma aside, I think the larger trend that we've seen over the last decade is, of course, consolidation, private equity, and just generally a sense that healthcare is business and not a
hmm
vocation. And I think that we train healthcare professionals to think of it as a vocation and something that has an inherent good. And that, yes, you have to make ends meet financially, but that shouldn't be the dominant driver. And of course, the culture of healthcare management is that finances are everything. And so that trend has meant that there's a parallel trend in the healthcare workforce experiencing moral distress and injury, and leaving the field when they can afford to, because it just is different from what they had hoped and expected it to be.
So last but not least, getting a little bit more practical of what can people do to, if they experience moral injury, ways to reduce it, or even something an organization or manager might try to do to minimize this experience of moral injury.
Yeah. So, there obviously there's no silver bullet. This is, as a subjective experience, we're talking about the realm of relationships and emotions. These are relationships that are broken down. This is something that Wendy Dean emphasizes a lot. Um, it's the loss of trust. It's the
Mm,
broken relationships. And so the starting point really has to be acknowledging that there's a real problem in the relationship, and that there is moral injury. The second thing that I would consider would be what I call shared governance, which is
mm,
the idea that to build trust, you have to give voice to the employees.
hmm
And in academia, we take it for granted. The faculty has sort of a tripartite structure of governance in public and nonprofit universities where we have a voice. Sometimes it doesn't work very well, and sometimes it works well. But structurally, we have the system in place where we have a voice. In hospitals, there are medical staffing committees where only physicians participate. Nurses have gone off in their own direction, creating sometimes nurse staffing committees or magnet accreditation. There's rarely, if ever, kind of a unified. Even the unions are kind of segmented by occupation, and so there's rarely kind of a mechanism for employees to voice their concerns. And I think it's really important for leadership to have a commitment to well-being, but also to create sort of the structures for employees to be able to have a voice in participating in decision making. So I think that it's not, again, it's not going to solve everything by itself, and it can work well or not work well, but it's kind of a prerequisite. It's necessary but insufficient. And then, of course, you need leadership that listens and that acts on what they're hearing. That's often called distributed leadership, the idea that leadership shouldn't be excessively centralized, particularly in very large,
mm.
complex organizations. You need information transparency, and then using that information to hold people accountable, in particular to hold supervisors and leadership accountable when things are going downhill rather than getting better. It all comes back to this somewhat ephemeral goal of trying to rebuild trust. I think what we
Hmm.
have is a crisis of trust. We see it across the country in terms of, um, the population doesn't trust government, doesn't trust the health system, and doesn't trust its clinicians. And well, the clinicians don't trust their healthcare organizations either. So it's not occurring in isolation, but I think healthcare providers are in a particularly difficult situation where they are the face of a system that they don't believe in. And so it's very hard to imagine that patients would be believing in them if they don't believe in their organizations. So, you really do need to start somewhere. And my sense is that the healthcare workforce is a really good place to start, to begin this process of trying to repair and rebuild relationships.
Well, thank you for your time, and that concludes our time together. Thank you again, Polly, for sharing your insights. We've included links to Polly and the Fitzhugh Mullan Institute's work in the comments or description section below. Of course, thank you all for watching, and thank you, Polly, for your time and expertise.
Thanks, Bernie. It was my pleasure.